Hello, my name is Steve Bradley. I'm a general cardiologist at the Minneapolis Heart Institute and the Associate Director of the Minneapolis Heart Institute Healthcare Delivery Innovation Center. And it's my pleasure to be with you today to talk about the ISCHEMIA trial entitled The Aftermath. I'll begin by saying I have no relevant disclosure of my talk today are to talk about where we were prior to the ISCHEMIA trial, review what the ISCHEMIA trial added to our knowledge, and discuss where we go now. So prior to the ISCHEMIA trial, it was really the COURAGE trial that had established where we were and where we were going in our understanding of management with stable ischemic heart disease. So as a reminder, the COURAGE trial enrolled and randomized approximately 3,000 patients to PCI versus PCI with optimal medical therapy. And in comparison of PCI versus optimal medical therapy over a 36-month follow-up, there was no evident impact of PCI relative to optimal medical therapy alone on death or myocardial infarction. But when we looked at patient-reported health status, abbreviated here PRHS, oftentimes referred to as patient-reported outcome measures or PROMs, we saw there was a significant difference in the severity of symptoms following PCI. So patients who underwent PCI had a significant difference in impact on angina severity and angina frequency over time. And this impact did decrease over time, suggesting there was a catch-up with optimal medical therapy, where at 3 years after PCI, there were similar outcomes. But for that period of 2 years, there was an improvement in patient-reported health status with PCI relative to optimal medical therapy alone. And in a sub-study that we conducted to validate appropriate use criteria that are largely based on severity of symptoms, we found that patients with more severe symptoms, patients who would more likely be considered appropriate for PCI, had a much larger benefit with PCI relative to optimal medical therapy alone. And there wasn't a similar catch-up phenomenon. So for patients with more severe symptoms, PCI had a definitive benefit in symptom burden. But as it related to those outcomes of myocardial infarction and death, there was thoughts that perhaps there was a subset of patients for whom PCI had benefit. And this stems from the COURAGE nuclear substudy. So in a subset of patients who underwent nuclear imaging study prior to PCI, prior to randomization, and in follow-up after PCI or optimal medical therapy alone, they compared patients' ischemic burden reduction between these two therapies. And we found that PCI, there were 33% that had a 5% or greater ischemic reduction following their therapy. Whereas with optimal medical therapy alone, fewer than 20% of patients had a greater than 5% ischemic burden reduction. When we looked at that outcome difference over time, patients who had a greater than 5% reduction in ischemic myocardial burden had a greater impact on myocardial infarction and death outcomes over time. And this was particularly important with patients who had moderate to severe ischemia, that baseline assessment of ischemia identified patients who had a larger likelihood of reduction in ischemic burden with their therapy and a larger likelihood of reduction in these outcomes of myocardial infarction and death. So from this sub-study, the question of ischemic burden reduction as it relates to PCI versus medical therapy alone was born, and thus the ISCHEMIA. So as a reminder, the ISCHEMIA trial was designed to randomize 8,000 patients with ischemia, either moderate to severe by imaging or severe by exercise ECG alone. In follow-up, power calculations in 2015 determined that a 5,000 patient sample would be adequate to determine approximately 20% reduction in outcomes between the two arms, and thus that was the study size that was finally enrolled and evaluated. But the enrollment itself had lessons for us. So of the 8,500 patients that were enrolled, a full 14% did not have obstructive disease, raising questions about the accuracy of stress imaging study in routine clinical practice, something that all practicing cardiologists are familiar with. And furthermore, a full 5% of patients had left main disease, and thus there was an important component of an anatomic assessment to identify patients with left main disease for whom randomization to optimal medical therapy was not felt appropriate. As a result of these 20% of patients for whom stress imaging did not adequately determine what might be an appropriate therapy, it starts to raise questions of the role of stress imaging in routine clinical. When we compare the ischemia trial outcomes, we see findings that are very similar to what we found in the COURAGE trial. So first and foremost, looking at myocardial infarction and death, there was no statistically significant difference in that composite outcome over follow-up period of time. However, it's important to note the crossover in events early versus late. So early and invasive strategy had a slightly higher rate of events, and this was driven by post-procedural myocardial infarctions, despite using a more stringent definition of procedural myocardial infarction than is used in the universal definition. Over time, there was a higher rate of non-procedural myocardial infarctions with the conservative strategy. And given that non-procedural myocardial infarctions are known to be associated with a more significant impact on patient outcomes, namely cardiovascular death, there's thoughts that over time that may have an impact on conservative strategy versus an invasive strategy. However, that was not borne out in the findings of the trial. Also, we see no evidence of treatment heterogeneity, meaning there was no difference in the impact of PCI relative to optimal medical therapy on the basis of how many vessels were involved, diabetes, or baseline ischemia. But again, it's important to look and note that a full 14% of patients did not have at least moderate ischemia when comparing the findings from the stress test as read in routine clinical practice relative to the core lab. And so this raises questions about the accuracy of stress imaging in routine clinical practice. Although it raises questions about whether or not there may still be utility to PCI in terms of impact on MI and death in patients with higher ischemic burden, it still demonstrates what happens in routine clinical practice. This was a pragmatic trial. Its findings apply to what we do in routine clinical practice. But it does raise questions about what might be important in the future in identifying ischemic burden and our approach to doing that. When we think about the real findings of the ischemia trial, to me, it validates the importance of patient-reported health status. So here we're looking at the Seattle Angina Questionnaire as a summary score. The Seattle Angina Questionnaire is a 7-item questionnaire to identify severity of angina symptoms and its effect on quality of life. The Seattle Angina Questionnaire summary score can be categorized into 0 to 24 for very poor to poor health status, 25 to 49 for poor to fair, 50 to 74 for fair to good, and 75 to 100 for good to excellent. And the baseline Seattle Angina Questionnaire summary score was 73 in the ischemia trial. So patients at baseline had fair to good health based on their angina status. When we talk about angina frequency, these are categorized into scores of 0 to 30, 31 to 60, 61 to 99, and 100 to reflect angina that occurs daily, weekly, several times per month, or no angina, respectively. And when we look at the impact of PCI relative to optimal medical therapy alone, again, we see findings similar to what was observed in the COURAGE trial. An invasive strategy with PCI resulted in a more significant benefit on on angina as measured by the Seattle Angina Questionnaire, both the summary score and frequency. But the effect is not uniform. It's dependent on the baseline severity of symptoms, and this is consistent with what we found in our post hoc sub-analysis of the COURAGE trial. Patients with more severe symptoms at baseline are much more likely to benefit from PCI relative to optimal medical therapy, with a cutoff right around 80 for where greater benefit is seen with invasive therapy. Patients with more severe symptoms have a larger impact on their overall angina severity and have a much higher probability of being angina-free relative to conservative therapy. And so that understanding of patient-reported health status, or that patient-reported outcome measure, is important in understanding what is the likely benefit on this patient as it relates to their angina severity, and important as it relates to having open conversations with the patient in terms of the risks, benefits, and which approach to management is most consistent with their goals of care. It's important to loop back to ORBITA. I've not mentioned it thus far, but I think that this is a perfect opportunity to put this into context. So the ORBITA trial was a therapy comparing sham PCI versus PCI in patients with stable ischemic heart disease. It only enrolled randomized 200 patients, so a small sample size. And there's an important component of how patients were enrolled in this trial that as it relates to what was done in COURAGE and ischemia and why we might not expect to see any benefit with PCI in this trial. So we know from both COURAGE and from ischemia that there is an important reduction in both ischemia itself, as determined from the COURAGE nuclear substudy, and ischemic symptoms, as determined for both the COURAGE and ischemia trial, with optimal medical therapy. Anti-angial medications work. They reduce ischemic symptoms. And in the ORBITA trial, patients were placed on optimal medical therapy, anti-angials, for 6 weeks prior to their PCI. So for 6 weeks, there was a reduction in patients' symptom burden as a result of being on these therapies. And we see this when we compare the baseline Seattle Angio Questionnaire scores to their follow-up immediately prior to PCI. There's a large improvement in Seattle Angio Questionnaire for both the PCI and optimal medical therapy arms. And we're starting to approach that 80-point threshold at which we might not expect to see benefit from PCI. So not surprisingly, in my mind, when we put patients on medical therapy prior to PCI, we start to negate some of the potential benefits of PCI. And for some patients, it's important to minimize the duration of the symptoms at all costs. So an upfront PCI 6 weeks prior to would have been done in ORBITA, for some patients, that's important to achieve reduction in symptom burden faster. So again, we're seeing here that medical therapy can improve angina symptoms. PCI on top of that, once you've reduced their angina symptoms, may not have much additional benefit. So with that, I'll ask, where do we go now? And I think, to me, this highlights the opportunity for cardiologists and invasive cardiologists to grab hold of the opportunity to address patient-reported health status as a primary outcome rather than a secondary outcome. For many patients, their health status and the symptoms that cause them to come see us in clinic are the most important thing that we can address. And if we have a therapy that can reduce those symptoms rapidly and safely, they oftentimes will hold on to that as the most important thing that we can offer. But we fail to routinely capture patient-reported health status so we understand whether our baseline prior to the procedure and understand the impacts of our therapies over time, and furthermore, to identify patients that have a decrement in health status over time, where reaching out and offering therapies may have benefit to them again. We started to do some of this work in the VA during my time there and prior to me leaving a little over 3 years ago. We had developed a process by which we would reach out to patients and capture patient-reported health status measures through an automated system. Those scores were then were offered to the provider prior to their coronary intervention, so we could understand their baseline health status. And then, based on the date of their PCI, the system was triggered to call the patient again, administer the health status questionnaire, and obtain their follow-up study scores. And for patients who had a decrement in health status, this gave us an opportunity to inform the provider to reach out to the patient and see if there were things that could be done to further optimize their health status and potentially address recurrence of obstructive coronary disease. The other component opportunity as it relates to ischemic heart disease is better assessment of coronary disease and ischemia from non-invasive testing. I think we're increasingly moving away from use of stress imaging and more towards anatomic assessment plus a functional assessment as a result of CT-FFR. We know from prior studies and what has been done as a part of NICE economic assessments that CTA appears to have benefits in terms of reduced cost for patients over time, and adding FFR to that increases the test sensitivity and specificity so that we're optimizing our therapies for patients and achieving best outcomes. And that's increasingly likely to be the goal of therapy. And it may have been that if the ischemia trial had been predominantly based on CTA and FFR, that again, the outcomes would have been slightly different as it relates to MI and mortality. Regardless, I think it's clear that there is an opportunity for PCI to be focused on symptom benefit. And if we address this, we continue to have a key role in the optimal care of our patients. With that, I'll close. I'll wish you a happy summer and a safe summer as we continue to move forward in this challenging time. I think our key component of what we as cardiovascular doctors do is to recognize that we are essentially fighting two fronts. One, of our routine care of patients with a highly mortal disease in the form of ischemic heart disease, while we continue to fight the battle of COVID, and recognizing that we have to fight both fronts at the same time. I wish you the best, and thank you again.